Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Somatic Mutations and Deletions of the E-cadherin gene Predict Poor Survival of Gastric Cancer Patients, by Giovanni Corso et al. My name is Jim Ford, and I'm an Associate Professor of Medicine and Genetics in the Division of Oncology at Stanford University School of Medicine in Stanford, California. My oncologic specialty is in GI cancers and cancer genetics. Gastric cancer is the fourth most common cancer worldwide and the second leading cause of global cancer deaths. The prognosis of patients diagnosed with gastric cancer continues to be dismal in spite of improving surgical and adjuvant treatment approaches, with a 5-year overall survival of less than 25%. This high disease incidence and poor outcomes continues to make gastric cancer a topic of active clinical and basic scientific research. Notwithstanding these efforts, relatively little is known about the molecular changes that contribute to the development of this deadly disease and how they may influence outcomes and therapeutic results. Gastric cancer can be considered a multifactorial disease since many inherited and environmental factors play a role in its carcinogenesis, including the host's genetic background, infectious agents such as Helicobacter pylori, and dietary habits. Gastric cancer is a heterogeneous disorder that can be divided into at least two main histologic types based on the Lauren classification, intestinal and diffuse type. These two types have distinct morphological, clinical, and epidemiologic features and may also represent a different molecular mechanism of tumor development and progression. The identification of germline E-cadherin, or CDH1 mutations, in families with hereditary diffuse gastric cancer, known as HDGC, provided early insight into the initial changes that promote gastric tumorigenesis and established CDH1 as a bona fide tumor suppressor. Subsequent studies indicated that while germline CDH1 mutations are common in hereditary gastric cancer of the diffuse, but not intestinal type, somatic mutations in CDH1 are frequently identified in sporadic gastric cancer of both major histologic subtypes. In addition, somatic epigenetic alterations, such as CDH1 promoter hypermethylation, are present in diffuse and intestinal type tumors and result in gene silencing. This epigenetic silencing of CDH1 gene expression represents the, quote, second hit in approximately 50% of hereditary diffuse gastric cancer, whereas the prevalence of CDH1 promoter hypermethylation in sporadic gastric cancers ranges in estimates from 11 to 46%, depending on the histologic subtype. Relatively small sample sizes and a focus on hereditary cancers or a single histologic subtype has hampered previous studies evaluating the prevalence of CDH1 somatic mutations in gastric cancer overall. The current study by Corso et al. Evaluates a large set of familial and sporadic gastric cancers to provide a more comprehensive analysis of the prevalence of CDH1 somatic mutations and their correlation with patient survival. The authors analyzed 246 patients with sporadic or familial gastric cancer for CDH1 structural changes, either mutation or loss of heterozygosity, or epigenetic alterations, that being CDH1 promoter hypermethylation. The results indicate that overall, 31% of gastric cancers carried CDH1 alterations, 2/3 of which were epigenetic alterations, and 1/3 were structural alterations. Those patients with CDH1 structural alterations displayed a poorer overall survival than those with either no changes or epigenetic changes only. The authors further report that CDH1 alterations, both structural and epigenetic, were found in 27.5% of intestinal type and 38.4% of diffuse type gastric cancers. While these alterations were not associated with a worse overall survival in patients with diffuse type tumors, there was a strong association between CDH1 structural alterations and poor overall survival in patients with intestinal type tumors. The major finding by Corso et al. that nearly one-third of gastric cancers harbor somatic CDH1 alterations, and that those with structural alterations carry a poorer prognosis, raises the question of whether somatic CDH1 alterations should influence clinical management of gastric cancer. While the findings in this study significantly clarify the extent of somatic CDH1 alterations in gastric cancer, there continues to be insufficient evidence to warrant regular CDH1 alteration analysis as a standard prognostic indicator or for predictive use in therapeutic decision-making. However, incorporation of this and other molecular features to more specifically characterize gastric cancers should certainly be part of the design of prospective studies of surgical and adjuvant therapy for this disease. The role of epigenetic changes in tumor suppressor silencing through promoter hypermethylation in human cancers has raised the specter of using demethylating agents such as 5-azacitidine as a therapeutic intervention. Large-scale changes in DNA methylation have been noted in the gastric cancer genome, and the CpG island methylator phenotype, or CIMP, C-I-M-P, may predict for a poor outcome independent of tumor stage. A large number of genes that are suppressed by hypermethylation have been reported in gastric cancer, in addition to CDH1, including DNA mismatch repair genes, P16, and MGMT, or O6-methylguanine DNA methyltransferase. Whether therapeutic demethylation of some or all of these genes in gastric cancer may lead to tumor responses has yet to be tested. The use of demethylated agents has also been considered as a potential chemoprevention strategy for germline CDH1 mutation carriers to slow or reverse the epigenetic second hit that inactivates CDH1 expression. While such an epigenetically targeted approach awaits further investigation in gastric cancer, there is mounting evidence that somatic alterations, including copy number variations in key oncogenes such as amplifications of HER2, FGFR2, and MET, represent viable treatment targets for which therapeutics are already approved or currently under investigation. Individual molecular profiling of gastric cancers at a whole genome level have revealed a number of known, such as P53, P10, or PIK3CA, as well as previously unreported, such as ARID1A, somatic gene mutations, and pathway alterations. Of more immediate potential application, somatic copy number aberrations have been found to be very common in upper GI cancers. 28% of gastric cancers have been shown to harbor amplifications in targetable membrane tyrosine kinases. The HER2 oncogene has been found to be amplified in approximately 12 to over 20% of gastric cancers, and a phase 3 trial investigating trastuzumab treatment of HER2-positive gastric cancers demonstrated an increased overall survival and response rate. Additional amplified genes that are currently being explored as therapeutic targets in the clinic include FGFR2, EGFR, and MET. Small molecules and therapeutic monoclonal antibodies are in development for each of these targets, and their role in gastric cancer as single agents and in combination with chemotherapy is being explored in ongoing phase 1 and phase 2 trials. Early results suggest that amplifications of each of these potential targets occur in approximately 5 to 15% of gastric cancers. However, whether they are mutually exclusive or whether various combinations of these oncogenic targets will occur in individual tumors remains unknown. Furthermore, significant genetic heterogeneity has been shown to occur within and between primary cancers and individual metastatic sites. This is clearly the case for gastric cancers as well and will prove challenging for rationally designed targeted therapy approaches. Nevertheless, initial studies such as this one in the current issue of the Journal of Clinical Oncology and others are defining the genetic and epigenetic landscape of gastric cancers. They suggest, as have been appreciated in breast cancer for some time, that multiple genetic and molecular subtypes of gastric cancer exist beyond those defined histologically, and that the genomic profiling of individual tumors may present unique treatment options for patients. As genomic analyses become an increasingly available option for evaluating and identifying treatment targets in an individual's tumor, clinical oncologists will have greater therapeutic options at their disposal, but will also be required to understand the genetics of their patient's disease. The goal of personalized cancer medicine is to understand the relevant genetic factors underlying a particular individual's tumor and then tailor therapy to that individual. Such studies as this one and others discussed in this editorial will hopefully lead to improved outcomes using drugs and therapies targeting specific gene products and leading to synthetic lethal interactions with aberrant cancer-associated pathways. I'd like to acknowledge support for this work from the Gastric Cancer Foundation and the V Foundation for Cancer Research. This concludes this JCO podcast. Thank you very much for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.